This is part 2 of the older adult. As you interview older adults, you'll need to modify your usual approach to obtaining a health history. As with all patients, your demeanor should convey respect, patience, and cultural awareness. Be sure to address older patients by an appropriate title or their last name. Please do not call your patients honey or sweetie. So the approach to the patient. Again, you should pay close attention to the office environment. You want the temperature to be comfortable. You also want to face the patient sitting at eye level. Make sure that there's no distractions and it's as quiet as possible. I want you to remember that about 50% of older adults are hard of hearing, so the distractions will be disrupting. So your content and pace of the visit, think about this, that often older adults measure years left, not years that they've lived. So pace and focus your visit in those terms. It's also interesting that eliciting symptoms in older adults tends to be much more challenging. They tend to underreport, so you've got to ask direct questions. Also, if you will use evidence-based screening tools, that'll help increase the time you have to listen while obtaining some real important information. And last, the cultural dimensions of aging are imperative for you to focus on. As I said earlier, older adults tend to underreport their symptomology. I also want you to realize that they also have atypical presentations, particularly acute illnesses. And the book gives some great examples of that on page 966. Okay, so they review cardiac symptomology, thyroid issues, and cardiac dysrhythmias and how an older person presents. So please look at that closely. There is something called a geriatric syndrome, which is where you manage increasing number of interrelated conditions. This cluster of different geriatric syndromes is often multifactorial conditions that involve interactions between identifiable situations, specific stressors, and underlying age-related risk factors, really resulting in damage across multiple organ systems. And the author again does a good job on page 967 of explaining that. Really, experts state that evaluating functional status, frailty, and other geriatric syndromes while simultaneously addressing individual disease processes is actually at the heart of geriatric approach in primary care. So it's especially important to recognize these syndromes because symptoms may cluster in patterns unfamiliar to the patient, but you can pick those up. In this slide, those last couple of statements are relating to this about carefully assessing symptoms, especially fatigue, loss of appetite, dizziness, pain for underlying clues of disorder. Ensure written instructions are in large print so that they're easy to read. So cultural dimensions are just having the knowledge and skill about the cultural dimensions of aging. They are a cornerstone for you to improving health care in rapidly growing older adults of diverse ethnic backgrounds. It interested me to look at the statistics on page 968. African Americans, Hispanic, Asian, and American Indian, the percentage of minority age group 65 years and older is increasing rapidly. And they even give a comparison of geriatric diversity now as opposed to 2050. Most of y'all will still be practicing at that time. We know this is impacted by the demographics of aging, are only a hint at how older adults in different ethnicities experience suffering, illness, and the decisions about health care. And we really know that culture shapes beliefs about the entire spectrum of aging, work and retirement, perception of health and illness, utility of meds, use of healthcare proxies, and preferences about dying. This is just to name a few. The health history is reviewed in detail on page 971. And those are special areas of concern that are related to the older adult. Activities of daily living. I think we're all familiar with bathing, dressing, toileting, transferring, continence, and feeding, but instrumental activities of daily living are a higher level of functioning. That's using the telephone, shopping, preparing food, laundry, housekeeping, transportation, taking your own medicine, and managing money. So here's some areas of health promotion and counseling that are related to older adults. And I think they make sense to us. If you'll look, there is a couple of unique ones, particularly for dementia and mild cognitive impairment, and also assessing for elder mistreatment. But I think the one that really stands out also to me is the depression. Depression is very much under-recognized and underdiagnosed in the elderly. Our author asks a couple of questioning and gives you the answer. I'm not going to review that this time. So let's look at the sixth vital sign, assessing functional status. It's imperative we do this. There's a special emphasis on maintaining independence and optimal level of function. Really, that healthy aging. Primary focus is on maintaining functional status, trying to really reduce any loss of it. And I really like that 10-minute geriatric screener. It's a performance-based assessment. It doesn't take a lot of time. It's very accurate. It looks at physical, cognitive, and psychosocial factors. I also want you to go over in detail the risk factor for falls and the information that was provided through the CDC. Again, our author asks another question and gives you the answer and rationalization. So let me just spend a couple minutes on the physical exam of the older adult. And I think that what these last couple of slides have done is just tried to heighten the uniqueness of the physical exam. Everything would be alike as in the middle to young and middle adult, but there's a few specific areas, such as your general survey looking for undernutrition or malnutrition, slowed motor performance, loss of muscle mass, and weakness. And those imply frailty. You know, frailty is a multifactorial geriatric syndrome. It is characterized by age-related lack of adaptive physiological capacity, and it occurs even in the absence of an identifiable illness. It signifies that muscle loss, as this author has said, decreased energy, exercise, intolerance, and decreased physiological reserve, with increasing vulnerability to those physiological stressors. The next is vital signs, and isolated systolic hypertension after 50 triples the risk of coronary artery disease and also stroke, but we went over that earlier for the pathophysiology behind systolic hypertension. Just know those issues and what causes it. Again, skin, the physiological changes of aging, the loss of collagen, there's thinning, a loss of elasticity, turgor is decreased and wrinkling. Being able to recognize actinic purpura and identify ways to reduce the risk of skin tears and skin breakdown. Headache, ears, eyes, nose, and throat. Really conducting a careful and thorough evaluation of the head and the neck, paying very close attention to vision, to smell, taste discrimination, dentition, oral care, salivary properties. Do they have enough salivation? And then a thorough assessment of the thyroid gland and the vessels on the neck. Lung and thorax, you're always going to perform the usual exam, noting any subtle changes in pulmonary function. I had told you, the lungs lose their exercise capacity, but they still have a pulse ox typically over 90%. Cardiovascular system, again, reiterating that S3 suggests dilation of the left ventricle from congestive heart failure, and systolic crescendo, decrescendo murmur in the second intercostal space suggests aortic sclerosis or aortic stenosis. And remember what I told you, how you discriminate between those two on that carotid upstroke. So go back and review that information. It's very important. Also, if the bruit is evident in the carotid, suggesting atherosclerotic disease, then you can guarantee almost emphatically that it's present in the coronary artery disease. Peripheral vascular, diminished or absent pulses may indicate arterial occlusion. It is never normal for a diminished or an absent pulse, so that has to be investigated further, and you should be checking the pulses on all extremities. Abdomen, there is a widened aorta, and if there is an evident pulsatile mass in the abdomen, you're looking for aortic aneurysm. And remember those risk factors: male, over 70, hypertensive, a smoker. Just get in the habit of measuring the aorta as you listen for bruits. Breast and axilla, lumps or masses are not considered normal, and further evaluation will be required. Female genitalia and pelvic exam, just real careful and time for positioning. Also remembering that the vagina is drier and it is shorter, and so you have to pick your equipment correctly. Male genitalia, just pay special attention to assessing for masses in the rectum and nodulary or masses of the prostate. Do not make the assumption that these men and women are not sexually active. You have to ask direct questions. Musculoskeletal, you're looking for joint deformity, deficits in mobility, or pain with movement that requires a more thorough examination. Arthritic changes, trying to discriminate between osteoarthritis or a systemic type of arthritis, psoriatic or rheumatoid. And then nervous system, you must do a thorough neuroevaluation. If any deficits are noted, you want to also put a focus on memory and affect and abnormalities of gait, balance that could correlate with the risk of falls. Thank you for your attention.